Hi, welcome to NEET PG Core Revision series in Pharmacology, where I am going to talk about the important topics for the upcoming NEET PG examination. Today, we are going to discuss about the anti-non-retroviral and antiretroviral drug. So, let's get started. Now, first in the anti-non-retroviral drugs. So, what are the important points to know for us? So, which are the drugs which are used for treatment of various herpes infections? So, for herpes simplex virus and varicella zoster or herpes zoster virus, our drug of choice is oral valacyclovir. So, we prefer this to acyclovir. So, valacyclovir. Then drug of choice for HSV encephalitis. So this is indication for IV acyclovir. Remember, acyclovir has an important side effect that you should know, that it is a nephrotoxic drug. Nephrotoxic drug. Now, acyclovir needs activation in two steps. One in the virus and second in the host. So we have virus kinases and then we have the host kinases, which ultimately activate it to the triphosphate form. That's the ultimate active form. So acyclovir needs activation. Now, resistance to this drug or these drugs occur when there is mutation in this particular step. The viruses, they will mutate and they will not allow the drug to actually get converted into the monophosphate. So there in those cases, these particular drugs will not be effective. So for this, we have some other drugs like cidofovir, foscarnet, trifluridine, which will bypass that step. So these drugs, you see this step, they do not require any virus enzyme activation. So they bypass this virus step. So they can be given in case of acyclovir resistant herpes. So cidofovir and foscarnet. What else should you know about cidofovir? That it's a myelotoxic drug. Myelotoxic drug. And foscarnet can also cause electrolyte imbalance. So these are the two important things that you should be knowing about this particular drug. Moving on to the drugs for CMV, cytomegalovirus infection. Now, oral ganciclovir. This is a drug of choice for CMV retinitis. While if we talk about IV ganciclovir, this can be used in case of CMV pneumonia. So this is preferred for CMV pneumonia. Ganciclovir, remember the important adverse effect, which is bone marrow depression. So we have to take that into account. Then we have some newer drugs also for this. We have letermovir and maribavir. So remember that. We always understand that it is to do something with the viral infection. Then influenza, drugs for influenza. So it is influenza A, B and bird flu. So we have drugs for these infections. Now, the first group or the first drug which we have amantadine and rimantadine, they are only active against influenza A, not against B and the other. And what is their mechanism of action? They inhibit or block the M2 proton ion channel. This M2 proton ion channel, if it is blocked, there will be no uncoating of the virus. The virus needs to get uncoated. So there is a coating in the virus, right? And uncoating is required. That means this needs to go away. Now, this uncoating, for it to go away, this is an important channel, M2 protein ion channel. If this is inhibited, then there's going to be no uncoating of the virus, as it will not be able to replicate. So that is the mechanism of action of this drug. But we don't use this currently, so rarely used now. You remember, amantadine is an anti-influenza drug, but it is used in case of Parkinsonism also. So it is not much used now. Coming to the most important out of this in the anti-influenza drugs, we have oseltamivir, zanamivir, and peramivir. Now, oseltamivir, O for oseltamivir, an oral drug, this is a one. And zanamivir is usually given, it is inhalational form and given in case of oseltamivir resistant cases. Then peramivir can be given in single dose and it is given as IV formulation. Now, they are effective against all types of influenza, right? So, influenza A, B, and also the bird flu. Remember, Tamiflu was a drug, so that is given. Important thing, what is the mechanism of action? Mechanism of action that these are neuraminidase inhibitor. Therefore, the virus can't be released. Can't be released. So let's say this is a structure, the cell where the virus is, growing inside and it is, replicating inside the cell. Now, to spread to the other cell, it needs to be released from here. So what happens here? There is neuraminidase which is present here, and this needs to attach to the host cell membrane, and ultimately the virus will be released, right? So the virus will be released, right? But this step is prevented by oseltamivir and the like drugs. Therefore, it will not allow the release of the virus, so the infection is not going to spread. That is the major mechanism. Now, treatment, whenever we are using it for treatment, we use it for a period of 5 days. Prophylaxis, 2 extra days, right? There's a newer drug which is veloxavir, and this is given as a single dose oral treatment, right? Single dose oral treatment is given with this drug, and this inhibits the initiation of mRNA synthesis, right? So this inhibits the initiation of the mRNA synthesis. It has a different mechanism than the others. So 3 groups here we have in the influenza. One is targeting the M2 protein ion channel, that is amantadine. The second are the neuraminidase inhibitors, and the third one inhibit the initiation only of the mRNA synthesis. Then drugs for hepatitis B. Now, anti-hepatitis B virus, the first line drug is we have tenofovir and entecavir. These are the 2 first line drugs. Tenofovir is contraindicated in children less than 10 years, and they are safe in liver disease, right? But not safe in renal disease. Now, tenofovir, if you're given for a long term, it has a problem of causing bone marrow depression. So that's why we are apart in children as well. Other drugs which can be given with this drug, they're not the first line, but what other drugs can be given is lamivudine, edifovir, and we have interferon alpha. And interferon alpha given for 48 weeks. Now, very important, interesting question is, which are the 3 drugs which can be used both in HPV infection as well as the HIV infection? So, the mnemonic is LET drugs. So, L stands for lamivudine, E stands for emtricitabine, and T stands for tenofovir. So these three drugs can be used for both managing the HPV as well as the HIV infection. Coming to the anti-hepatitis C virus drugs. Now, initially we had few drugs like ribavirin, interferons. They are toxic also, not the way direct acting. But now the treatment has been revolutionized with the availability of the directly acting drugs on the virus itself. So what are these drugs? That is very, very important. So we have drugs like cimeprevir and paritaprevir. So what is the role of these drugs? So previrs, these are protease inhibitors. So what are these? These are protease inhibitors. And what is the role of protease enzymes basically? The protease is responsible for cleaving of the polyproteins into smaller proteins. So protease inhibitors, the protease as such, they cleave the polyproteins into smaller proteins, right? So this will get now inhibited. So there is inhibition of these because otherwise polyproteins are of no use to the virus. They need small meaningful proteins for them. So that is not there now. So the target for the action is NS3/4. So this is the target now. The second target is they are going to target NS5B, right? They target NS5B and the drugs are sofosbuvir and dasabuvir. So here, how can you remember? They have buvir, B-U-V-I-R, B-U-V-I-R. So B, remember, they are going to target the NS5B. And when they target this NS5B, they inhibit the viral RNA polymerase. RNA polymerase. Then we have the other drugs, daclatasvir and velpatasvir. So they are asvirs. So they are going to target NS5A. So A they are going to target. Okay. So bovir targets NS5B and asvir targets NS5A. That is important. This is how you can remember this. So they inhibit viral replication and assembly, both viral replication and assembly, both. Then these were the directly acting drugs. Then we have other drugs like ribavirin. Again, it has a virus. It means again it is virus, VIR in them. Virin, that is they inhibit the viral RNA synthesis. RNA, so the VIR RNA synthesis, inhibit the viral RNA synthesis, right? That is the important thing to know here. So they or this drug is used orally in chronic hepatitis C infection along with pegylated interferon alpha. Important is that it's used along with pegylated interferon alpha. So interferon alpha here, we use it for a long period of time, 6 to 12 months. What is the other use of ribavirin? So ribavirin also used in RSV treatment. Respiratory syncytial virus treatment also used in RSV treatment. For prophylaxis of RSV, we use palivizumab. Palivizumab. Remember these important drugs which are asked. So for RSV treatment, we are using ribavirin, while for prophylaxis, we use palivizumab. ADRs of ribavirin, it can cause hemolytic anemia, and bone marrow depression. Even interferons can cause bone marrow depression. So these are the important points about drugs acting against hepatitis C virus. Now moving on to the next, we have the antiretroviral drugs, right? So initially we have done the non-retroviral, now the antiretroviral drugs. Now we have various drugs which can be groups classification. So remember what happens in retroviruses is that this is a retrovirus. It has GP120, it has GP41. Now GP120, the role is to cause attachment to the host cell. So for the attachment to the host cell, this is causing the attachment to the host cell. And on the host cells, we have CCR2, CCR5, and CXCR4, right? We have these. And we have CD4 also on the host cell. So they are helping in the attachment, and and ultimately the fusion occurs by GP41. This is important for the fusion to the host cell. So first attachment and then the fusion, and then what happens, this virus which contains the RNA, it will enter inside. So once the fusion is there, then this will enter inside the host cell. There is an enzyme it is present actually along with the virus only. So this is the enzyme here, which is called as, reverse transcriptase enzyme. What is the role of reverse transcriptase enzyme and why the name? Because normally what happens if we form RNA from the DNA? So normally RNA is formed from DNA, but in this case, the reverse is happening. From the viral RNA, we are forming the viral DNA, double-stranded, right? So this is happening in the host cells. So when this happens, the enzyme reverse transcriptase is important. After that, what is happening is it goes inside the nucleus. Already in the host nucleus, there is DNA. So let's say we have a DNA here in the host nucleus. This viral DNA is going to get integrated into the host DNA. So here you see this is a host one, and here the viral DNA also gets integrated. And now it becomes a part of the host DNA. So this responsibility is with integrase. So it is integrating the viral DNA into the host DNA. This is integrase. So then there is replication, then there is formation of mRNA, right? The protein synthesis occurs, replication is occurring here. So when the proteins are formed, so this is all yet the cell only. Now then the proteins are formed. So when the are formed, again these are polyproteins being formed, right? So let's say there are so many from here, the synthesis, polyproteins are being formed. They need to be now broken down into simpler proteins, smaller proteins. And for that, we require protease. So then smaller proteins are formed and other viral components, they come together, and there is another. Now these viruses, they are formed and then they're going to be released. So Your antiretroviral drugs, they are going to target these different steps. So for example, the first step that we have is for entry inhibitors, right? So the entry inhibitors, either they target the GP120 or 41, or they block this so that the entry of the virus can be blocked. Second step is you block this reverse transcriptase. So we have reverse transcriptase drugs. So nucleoside and non-nucleoside and nucleotide reverse transcriptase inhibitors, right? Then we have integrase inhibitors, which are going to prevent the integration. Then we have the protease inhibitor. So all our drugs are going to target these particular steps. So with this background information, let's now move on to the drugs. So first we're going to do the entry inhibitors. Remember, the first step is GP120. So to block this first step, we have a drug, fostemsavir. Okay. So remember, it has FOST. FOST means first. First. So the first step that is blocked is the attachment. So GP120 is responsible for attachment. So fostemsavir is going to block this attachment. The drawback with fostemsavir is that it can cause QT prolongation. QT prolongation. Next step is fusion. So GP41, it is responsible for fusion. So 40 starts with 4. Fusion starts with F. 40 means F. F. Fusion also has this. So fusion inhibitor. So F, F, and the name also has few. The name is N4V die. Okay. So remember F of 41, few of fusion, and few of 4V-tide. N4V-tide. So that is the step number 2. Then we have drugs binding to CCR5 or binding to both CCR2 and CCR5. So CCR, you remember that R, just remember rock. So these are rocks. So we have a smaller rock and we have a bigger rock. So if only one CCR2 is blocked, we require a smaller rock over there to block it. But if 2 of CCRs have to be blocked, we require a bigger rock. So we have 2 drugs. The one with the smaller spelling is going to block the CCR5. And that drug is Mara Y rock. So they are rocks which are going to block this CCR. So also there's another way to remember this. Mara Y rock. Y is viral and V stands for 5 in Roman numbers. This is 5. And so this is only again CCR5. The ones or the drug which blocks both of them. So that has a longer name. So what is that name? Let's do. It is Sensicrivirol. Right? Sensicrivirol. And it is going to block both CCR2 and CCR5. And see how many C's are there? 2 here, 2 here, 4 C's. So this also has 1, 2, 3, 4. 4 C's. So that's another way of remembering. But you can remember the one with the bigger spelling, that's the rock with the bigger spelling is blocking both these. And one with the smaller one, Maraviroc, is blocking only CCR5. Then we have another drug, which is going to be, it's a monoclonal antibody. And it is not only against the CD4. So it is not targeted only against CD4, but also CCR2 and CCR5. So that drug is called as Ebalizumab. It's the only monoclonal antibody out of the blood. So in Bali, right? So we have, you stay for 4 days, CD4. Stay for 4 days in Bali. Okay, remember that way, CD4, Ebalizumab. Then we have a capsid inhibitor. So capsid protein they block and the name is Lina kappa V. So it has cap in the spelling only. Lina kappa V. So they are going to inhibit the capsid. So that is the first step. Now, second is to block or inhibit the reverse transcriptase. So we have reverse transcriptase inhibitors now with us. So we have first nucleoside reverse transcriptase inhibitors. Remember, a mnemonic here for these drugs is Lisa did stay. So L is lamivudine, E is emtricitabine, Z is zalcitabine, then we have zidovudine, and then we have A is abacavir. Did means didanosine and stay means staviodine. So these are your nucleoside reverse transcriptase inhibitors. So which of them is the best or are the best tolerated NRTIs? Here we have drugs like lamivudine and emtricitabine. Remember, emtricitabine has one issue or one problem, adverse effect of causing the hyperpigmentation of the palm. So if the question is an image-based question, which of the antiretroviral drugs is associated with hyperpigmentation of the palms and soles, it is emtricitabine. Most common side effect of NRTIs are the rashes. So it's the rash. Major side effect of zidovudine. It's one of the oldest drugs. And what is the major drawback with zidovudine is myelosuppression, bone marrow depression. So that is myelosuppression. So therefore, it is contraindicated if the HB of the person is less than 9. Then we will not like to give this drugs. Also, it can cause myopathy and it can cause hepatotoxicity. Okay. Dose limiting side effect of didanosine, that is pancreatitis, right? So pancreatitis is the dose limiting toxicity, but didanosine can also cause peripheral neuropathy, right? Apart from this, it can also cause peripheral neuropathy, but this is a dose limiting side effect. Major side effect with staviodine, again, it can cause peripheral neuropathy and lipodystrophy syndrome. Side effect with abacavir, it can cause hypersensitivity reactions. Then, which of these drugs should not be combined together when you give? So, do not combine zidovudine with staviodine. Why? Because they can antagonize each other. So, pharmacodynamic antagonism, so they can antagonize each other's effect. Also, if you give zalcitabine with didanosine and with staviodine, there is increase in the risk of peripheral neuropathy. So these combinations you should be avoiding. Then we have nucleotide reverse transcriptase inhibitors like tenofovir. So in the tenofovir, important is that it is a very nephrotoxic drug. And it is not used in children less than 10 years or if the weight is less than 30 kg because we don't have sufficient data to prove its safety in these people. All right. So there was one MCQ in the previous years. Which drug binds to CD4 as well and has activity on both CCR5 and CXCR4 in the tropic HIV infections? So CD4, where you see it is Bali. Bali has 4 days. So this is ebalizumab. Okay. Now here, maraviroc is only active against CCR. We said 5. Elvitegravir. Wherever you see gravir, it is an integrase inhibitor. So these are integrase inhibitors. Then navirs. Navirs are protease inhibitors. Remember this way. Then we have NNRTIs. Here we have nevirapine. So important thing to know about nevirapine, it is the drug of choice for prevention of vertical transmission in HIV, right? So from the mother to baby prevent. Efavirenz, remember it has a one major drawback, which is psychosis. Now, this is a newer drug which has a slightly different mechanism, that it is a nucleoside analog reverse transcriptase translocation inhibitor, right? Nucleoside analog reverse transcriptase translocation inhibitor. Then we have integrase inhibitors. So integrase inhibitors, I told you they are called as gravirs. So we have dolutegravir, we have elbtegravir, we have raltegravir, and we have long-acting cabotegravir. So to boost the effect of elbtegravir, can we give some drug? Yes, we can give a drug called as cobicistat. How it boosts? Because it is a inhibitor of an enzyme cytochrome P3A4, which is responsible for metabolism of elbtegravir. So if you inhibit this, there will be increased levels of elbtegravir for some time. So it boosts the effect of elbtegravir. So remember this. Side effect of these gravirs is they can cause myopathy and they can cause rashes. So myopathy is more common with raltegravir. Okay. Moving to protease inhibitors are called as NRTIs. Now, in the NRTIs, the important thing is that they are going to inhibit the assembly because they will not allow the proteins to break down into smaller components. So they ultimately they interfere with the assembly of the viral proteins. Now, all of these drugs, they are metabolized by CYP3A4 except nelfinavir, which is metabolized by CYP2C19. Because of the reason, we'll see that a drug which is one of the most potent enzyme inhibitor of CYP3A4, which is ritonavir, cannot be given with nelfinavir. This ritonavir is main role is to boost the effect of the other drugs because it is going to inhibit CYP3A4 and it will increase the effects of the other protease inhibitors because they will not be metabolized faster. But it cannot be given with nelfinavir because the enzyme is different here. So apart from nelfinavir, it can boost the effects of the other protease inhibitors. Now, what about other drugs like elbtegravir, darunavir, atazanavir? The booster we use against or for this is cobicistat, just like we did just now, cobicistat. Okay. Now, out of these navirs, the least potent protease inhibitor is saquinavir. Okay. And it has a problem of causing QT prolongation. Okay. Indinavir. What is the drawback with indinavir? It is associated with nephrolithiasis and hyperbilirubinemia. Okay. Now, protease inhibitors have one classical side of adverse effect we should know, that is dyslipidemia. But the only protease inhibitor which does not show dyslipidemia is atazanavir. Atazanavir. They have no risk of dyslipidemia. Now, how do you treat dyslipidemia because of these protease inhibitors? So, the treatment of dyslipidemia is a drug called as tesmorelin. Remember this. So, no risk of dyslipidemia is by atazanavir. And another important thing is which protease inhibitor is associated with intracranial hemorrhage or hepatotoxicity, especially this one, which is more important, is tipranavir. Tip, right? Tip is the tip of the head, right? So it can cause intracranial hemorrhage. Tipranavir. Fixed dose combination is available of these protease inhibitors. For example, I told you because one is a booster drug, it is not used as such. It is only used to boost the effect of the other drugs. So we have ritonavir in around 10% plus ifivir, lopinavir. It's available as a fixed dose combination. So 90% is the drug lopinavir and 10% we add ritonavir, which increases the effect of the lopinavir. Now, let's do another MCQ. Which of the following growth hormone analog that is not used for treatment of growth hormone deficiency, but actually it is used for HIV associated lipodystrophy? So I just told you that drug is tismorelin. What about the other option? Let's see. What is quinanoline? It is just a distractor. It's not a drug at all. Only a distractor. Somatropin. Now, somatropin is recombinant growth hormone and it is used for growth hormone deficiency. Pegvisomant is a growth hormone receptor antagonist used in acromegaly. Right? So the correct option here is tesmorelin. The second question is, a patient with hemophilia on antiretroviral therapy presents with altered mental status accompanied by nausea, vomiting, and headache. Which of the following medications is most likely responsible for this headache? So remember, there is altered mental state, something wrong in the head, nausea, vomiting, headache. So there can be some intracranial hemorrhage or intracranial bleed. So I told you tip of the head, that is tipranavir. That is the important thing. Now moving on to the antiretroviral therapy. What are the drugs which are used for antiretroviral therapy? So here we have drugs like the first line drug. Remember the regime is TLD regime. That is tenofovir. We have lamivudine and we have dolutegravir. So these are the first line drugs that we use. Remember, tenofovir is contraindicated in children less than 10 years or where the weight is less than 30 kg because we don't have the safety data here. So, replace in such case with abacavir. Okay. Now, post-exposure prophylaxis, same drugs you're using. TLD. You have to start within 72 hours of the exposure and continue the treatment for 4 weeks or you can say 28 days. What about pre-exposure prophylaxis? Because you can give it in like where you suspect, like females when there are multiple sexual partners or in the other kind of people. So pre-exposure prophylaxis, what we do is we give tenofovir along with emtricitabine. All right. Prevention of vertical transmission. So very, very important that we use nevirapine. So here we use nevirapine. Nevirapine. So low risk infant, you can just give this syrup of nevirapine OD for 6 weeks. Right? If there's no other indication given, so you assume you give nevirapine syrup for 6 weeks once daily in a syrup form, obviously. But let's say there are high risk case and the female decides against breastfeeding. Then what you do? You give nevirapine plus you add 0 butane. You give this for 6 weeks. And if the female, the mother, wants to, right? So if the mother wants to do exclusive breastfeeding, then you do the same treatment with zidovudine, but you extend it to 12, depending on the condition. So these are the important points which we should know about the anti-non-retroviral and anti-retroviral.